Okay, sure. Maybe we'll get going. Firstly, I'm Alan Barrett. I'm the director of the ESRI, and it's a great pleasure to welcome everybody to today's launch, to launch the new report on primary care systems of Ireland and Northern Ireland. So again, as I think most people will be familiar, the report we're launching today is being done under the joint research initiative between the Shared Island unit of the Department of the Taoiseach and the Economic and Social Research Institute. And again, just a small bit of background, we began discussions, I think, with the Shared Island unit, it's probably about 18 months ago at this point, maybe even a little bit longer. Again, time got so strange over the last little while. But we had two overall sort of objectives when we began this research initiative. And the first objective was the following. I mean, given on the island of Ireland, we have this somewhat unique situation that we have a relatively homogeneous population, but we've got two systems on the island where we do things differently. We thought that, you know, there is a great learning opportunity here. And as scientists and social scientists, it's almost like this sort of, you know, neat little laboratory or whatever like that you have these two systems doing two things differently. And it provides an opportunity to learn about really what works well and what works less well across a whole range of areas. And within the research program, we were sort of eager to capture perhaps some of the lessons. The second strand that we were interested in then was areas of potential collaboration on the island of Ireland. And again, there was no sort of constitutional overtones or anything like that here. It was simply, we live on this island together. Are there areas of potential collaboration on the island which would allow us basically to sort of derive benefits for the residents of the people on the island of Ireland, regardless of constitutional status? So that was it. It was about sort of mutual learnings and also about the, you know, the possibilities of collaboration. So this is the third in the series of reports that we've produced, and indeed there's about 5 or 6 more in the pipeline. And I have to say, health actually is a really, really interesting area of study, because it almost offers the possibility of capturing the two objectives that I mentioned at the outset. Again, we've got one island but two health systems, so I think there's a real possibility for learning here. But we also have possibilities for collaboration. And I think this is one area already where there is some degree of collaboration across the island in certain areas of health. And I think that works very, very well. But you would imagine that the possibilities for expanding this are even greater. I should say I have I'm an economist by training, and my areas of interest were always things like labor economics and population economics and migration and a whole range of other things. A number of years ago, probably about 15 or 20 years ago, I decided one day that health was essentially too complicated for me, and I was going to abandon my efforts to try and think about the health system and comment on the health system. But I found, unfortunately, as an economist, life is never that simple. So I always remember in 2011, I was invited to go on the Irish Fiscal Advisory Council. And when you start looking at public expenditure numbers and public finances, it doesn't take you an awful long time before you arrive at health budgets, and you find yourself having to interrogate it. So, you know, I was pulled back into health. And then, much to my surprise, about a year ago, I was invited to become a member of the new Northern Ireland Fiscal Council. And any of our colleagues from north of the border will again realise that probably one of the sort of top issues in terms of public expenditure in Northern Ireland is health and the health system, and great concerns over the trajectory of spending and where it is all going to end up. So once again, in spite of my pledge about 20 years ago that I wouldn't think about health, I'm discovering that I'm being drawn back into health. And as the all Ireland dimension of this is now very much the sort of fore in my head and in my thinking. So I'm very much looking forward to today's event. I think, as you all know, the plan of action. In a couple of moments, we'll have a video presentation from the Minister of Health here in the South, Stephen Donnelly. Then my colleague Sheelah Connolly will take you through the findings of the report, and then absolutely delighted to say we have a lively panel discussion, hopefully with the three panelists who I'll introduce when we get closer to the time, and then hopefully we'll also have a little bit of time for questions and answers at the end, and hopefully we'll be wrapping things up then around 12:15. Just a quick note, unfortunately we're all sort of panelists, chair and everything we had been hoping to gather, but COVID hit both the ESRI and Trinity, I guess. So myself and one of our panelists, Nolan, unfortunately had to reverse ourselves, stay at home, and we're not able to participate in person. But great that some of the colleagues were able to gather in the ESRI offices. And great to hear the ESRI offices are still standing after such a long absence. That's always kind of comforting. So last thing that I want to say in this section is just a word of thanks from the ESRI to our colleagues in the Department of the Taoiseach and the Shared Island unit in particular. It's great to have been collaborating with them on this initiative for quite a while. I also want to thank Anne Barrington, who's the chair of the steering committee that oversees this project. And it's lots of interesting things happening, and hopefully we'll have another series of events as the year progresses, when we'll be discussing more of these sorts of issues. So with that, I think at this point now, I'll ask somebody to play our video from the Minister. So I guess it's my roll with their Colette moment.
Good morning, everyone. I'm really pleased to have the opportunity to say a few words at today's launch of this important report, which looks at primary care systems for Ireland and Northern Ireland. The event is part of the government's Shared Island initiative. This is an initiative that was launched by the Taoiseach in October 2020. It's an initiative through which we're aiming to enhance mutually beneficial cooperation, connection, and understanding on the island. And we're doing this through the framework of the Good Friday Agreement. As you're aware, the Shared Island unit in the Department of the Taoiseach is commissioning a comprehensive programme of research. This includes the work being launched and published today. The government has also established a Shared Island Fund. This is a fund of €500 million in capital funding. It's funding ring-fence for North-South projects over the next 5 years, which we will invest in co-funding North-South partnerships to build a more sustainable, connected, prosperous, and healthier island. I'd like to send my compliments to the ESRI for the report, and in particular to its authors, Sheelah, Aoife, Kieran, and Michael, in bringing it to fruition. This type of research provides independent and in-depth analysis to provide robust evidence-based policy formation. I note the observation in the report that recent reform proposals in both jurisdictions have highlighted the need to improve population health and deliver more care in the community. The report also correctly notes that differences between the systems provides us with an opportunity to examine how the different approaches and policies impact on patient and population outcomes. I'm interested in the findings on the focus parts of the research, in particular, GP utilization, use of preventative services, unmet medical needs, potentially avoiding hospitalizations and waiting lists for hospital-based services. As you're aware, we have a comprehensive reform program in place. Universal healthcare is the vision, and it's a vision for our health and social care systems where everyone has equal access to services based on need. Considerable progress is being made to reform Ireland's health services and modelling care in line with the vision of universal healthcare. Regional health areas will provide for the alignment and integration of hospital and community healthcare services at a regional level. The National Elective Ambulatory Care Strategy, which will change the way scheduled procedures, surgeries, scans, and outpatient services are arranged. It will do so to ensure greater capacity in the future and help address the waiting lists. Elective hospitals will provide additional capacity and also help address the waiting lists. 3 weeks ago, I launched a €350 million waiting list action plan. The plan identifies 45 actions as part of a comprehensive approach to targeting investment aimed at reducing waiting lists by 18% this year. I'm eager that we'll continue to learn from each other, north and south, to reduce the pressures on our hospitals and utilise this report to assist us. Finally, I see I'm followed by a number of really interesting speakers, so I hope you enjoy the event and study these findings. Thank you so much.
Great, and thanks to Minister Donnelly for joining us, and actually, again, I think capturing the essence of what the report is about. I should say, and I'm going to excuse myself on the basis of my COVID diagnosis, but of course, while this is an ESRI published report and led by Sheelah, we were delighted to have collaboration with colleagues in Queen's University, of course, Kieran O'Neill and Michael O'Callaghan. So I want to make sure I move quickly and acknowledge the contribution of the colleagues, and just say how important a cause, of course, it is when doing work of this nature, that we had collaboration from north of the border. So now it's my great pleasure to hand over to my colleague Sheelah Connolly. So I think, Sheelah, you're going to take us through the details of the report.
Thanks, Alan. So as Alan said, I'm going to provide just an overview of some of the findings from our report today, with my co-authors Aoife Brick from the ESRI, Kieran O'Neill from Queen's University, Belfast, and Michael O'Callaghan, who's a GP and a PhD candidate in the University of Limerick. And I think kind of the starting point for the work is that we all know that there's similarities and differences between the healthcare systems of Ireland and Northern Ireland. And in these conversations, generally, what we hear about and what we talk about is around the user charges and I suppose the relatively high use of user charges in the Republic of Ireland, in particular for primary care services. And you contrast that with Northern Ireland, where there's very limited use of user charges. Both systems I suppose, have kind of significant reform proposals or reform reports published in the last number of years. So the Irish Sláinte Care report was published in 2017, and Mr. Donnelly noted the idea from the report was about the introduction of a universal healthcare system in Ireland and the elimination of many of the user charges, I suppose, that we currently have in the system. And we know that if that was implemented, the two systems actually would have much more in common than they currently do. There was other components to the report as well. There was a part about removing, or I suppose, reducing the reliance on the hospitals and transferring care where it's appropriate into the community side and into primary care. The Bingoa report then for Northern Ireland, it was published in 2016. And again, so while it's different in the sense that there isn't a conversation around universal healthcare, but there was an overlap, I suppose, with the Sláinte Care report, in that there was, the authors recognised the need to reorientate the healthcare system, greater emphasis, greater funding for primary and community-based care, and also quite a lot of discussion in the report about the workforce shortages and poor morale. And I suppose what we were hoping to do then is just, okay, so we know there's these differences between the systems. Is there something that we can learn and that might be able to feed into the reform proposals on either side of the border? So in terms of specific objectives then, we sought to identify how the primary care systems of Ireland and Northern Ireland differ in terms of eligibility, workforce, and the current reform proposals. We sought to look at the demographic and socioeconomic composition of the populations in Ireland and Northern Ireland. And that's a significant project, I suppose, in its own right. And really, we just scratched the surface of that. But, potentially a lot of interesting findings coming from that sort of research. We sought to identify what comparable data are available on the primary care systems of Ireland and Northern Ireland. And I suppose without giving too much away at this stage, I can say that the amount of comparable data was fairly limited. And then to what extent do the available data allow comparative analysis of the healthcare systems to be undertaken? So just very briefly then, an overview, I suppose, of both systems. So the Irish healthcare system, it's a complex mix of public and private financing and delivery. It's an unusual system in a European context, and it probably has more in common, I suppose, with the American healthcare system relative to other European systems. There's a range of different eligibility categories, and I think somebody coming from outside Ireland, sometimes is surprised by all these different categories. So we know we have medical card holders who have an eligibility, I suppose, relatively similar to the general population in Northern Ireland, where they have access to a range of services largely without charge. We have GP visit card holders, who are people that either on income or age grounds are entitled to free GP visits, but they pay for other primary care services. And then we have the rest of the population who have subsidised public hospital services, subsidised drugs, but then they pay for a large number of primary care services as well. But then for particular groups of people and for particular healthcare services, some people have an entitlement for particular services at particular periods in their life. We've got a large proportion of the population covered by private health insurance. So usually year on year is about somewhere between 45 and 50%. And for most people, I suppose, that purchase private health insurance, it's so that they can access private hospital-based services because of long waits for many of the public hospital services. We don't have a list of registered patients. So while there will be a list within the GP practices of those with a medical card and with the GP visit card, for the private patients, sometimes I suppose they can be registered with more than one GP at a particular time. So there is no one definitive list of all the patients within the system. In terms of the workforce then, the GPs tend to be self-employed. Other healthcare staff are publicly employed, but we've got significant private provision, and there's, I suppose, issues in that in and of itself. But from a research perspective, we always find it very difficult to get any data on what's happening on the private side. In terms of the issues in the healthcare service, then I suppose the big ones that we hear a lot about at the moment are about workforce shortages, in particular for consultants, but likely to be an issue across various healthcare professionals, and also issues of access, and in particular because services aren't available at all in particular areas, or because there's very long waits. So the Northern Ireland system then, I suppose similar to the rest of the UK, in the period after the Second World War, they introduced a universal healthcare system. I suppose the Northern Ireland system and the other systems of the UK, there have been various changes, I suppose, and restructurings over time. But the one thing that most systems have held onto is the fact that they provide services free at the point of use. There's some private provision and financing, but it would be to a much lesser extent than it is in Ireland. And also the private and the public in Northern Ireland, similar to other countries, there's a greater divide and you don't have the overlap that you often see in Ireland. All patients, in order to access healthcare services, they register with the GP. They receive a health care number, which they can use across the various services. And it's a way, I suppose, of identifying the list of patients, the list of people within Northern Ireland. And I suppose despite those kind of differences between the systems, what we're seeing is that there's the similar challenges and similar issues in both sides, in that it's workforce shortages and issues of access. So very briefly then, I suppose, just on the demographic and socioeconomic composition of the two countries. So I think the status for 2019, there was 4.9 million people in Ireland and about 1.8 million in Northern Ireland. The age distribution is relatively similar. So this figure shows the proportions of the population in the various age categories. I think for the under 15s, it's about 20% of the population on both sides of the border that will be in that younger age category. Northern Ireland has a slightly higher proportion of its population then that are aged 65 and over. But in general, I suppose it's relatively comparable. The one thing then we tried to get a handle on as well, how does the population health in Northern Ireland compare to that in Ireland? And I suppose it's a relatively easy question to ask, but a much more difficult question to answer, because it's how do you measure health and how do you get one summary measure of health that really kind of neatly captures the population? And obviously different groups will have different experiences. I suppose the commonly used ones are, when you're comparing across countries like this, are things like life expectancy and infant mortality. So some colleagues in the ESRI, Bergen and McGuinness, they had a paper last year which looked at life expectancy over time. And what that showed was that if you were going back about 20 years ago, life expectancy was higher in Northern Ireland and the UK as a whole than it was in Ireland. Over time, both countries have had an improvement, so life expectancy has increased, but the increase has been greater in Ireland, so that now probably life expectancy is higher in Ireland than it is in Northern Ireland. We saw, I suppose, kind of a relatively similar pattern when we think about infant mortality, which is a measure of the number of deaths of those aged less than 1 in a particular year. I've included the dotted line there for the UK as well, just because the pattern for Northern Ireland is a bit erratic, because it's just fluctuations in numbers year on year. And what we're seeing is that if you go back to the earliest period of 2001, that in both countries, the infant mortality rate was about 6, which would be relatively high, I suppose, in a European context. We know that there's been improvements over time. So if we go back to 2018, which was the last year that we had data for, what you're seeing is that the infant mortality rate in Ireland is now under 3, but it's hovering around 4 in Northern Ireland. And the Northern Ireland rate seems to be tracking the rate in the UK. So this divide seems to have opened up over time. So in terms of the type of system level indicators then that we wanted to include, when we started off with this piece of work, we were very optimistic about all the indicators that we would include, and then had a reality check quite quickly when we realized the amount of comparable indicators was quite limited. So we were trying to get a sense of, well, what are the inputs to the system? What's the throughput? What's the activity? And how does that impact on outcomes? So for inputs, we were looking at the number of GPs. We had wanted to include other workforce in the primary care as well, but the categories and how they're defined differ between Ireland and Northern Ireland, so it makes that sort of comparison problematic. Expenditure data, we have to use Ireland and the UK because we in both countries they produce expenditure estimates, but what's included and not included differs, so it's not an easy assessment to make. Throughput, we talk in the report about utilisation, in particular GP services, I suppose, and there's been some work done in that area, and we summarise that work in the report. I don't cover it here just for time reasons, but we do just have a look at the kind of the screening and the vaccination rates. So those services, I suppose, that certain groups of population should be taking up, and it's kind of independent of people's health status. In terms of outcomes then, we're looking at self-reported unmet healthcare needs, avoidable hospitalizations and waiting lists for hospital-based services. Now, obviously, we would have preferred to have waiting lists for the primary care services, but again, we couldn't just get data on that for Northern Ireland. So the number of GPs, I suppose, a couple of things here to note. Data challenges, not just in terms of getting comparable data across Ireland and Northern Ireland, but actually getting good data within the countries. So there's no one list of GPs in Ireland. There's different lists, and they provide different numbers depending on how you define a GP and who are not included. For Northern Ireland, we don't have information on whole-time equivalents. So what we have is head counts, and we don't know whether people are working full-time or part-time, or what proportion of the population might be working part-time. From what we can see, looking at GPs per capita, there doesn't seem to be a huge amount of difference. Expenditure then, so the solid lines towards the bottom are public expenditure. It's expenditure by the state on healthcare. And it's Ireland, as I said, and the UK. And what we're seeing is that this should be adjusted for kind of purchasing power and differences in prices across the countries as well, is that the public expenditure in Ireland is above that in the UK. There's I think they come together quite closely in 2014, because that was kind of the end of a period in Ireland where health expenditure was relatively stable while it was increasing in the UK. The bigger divide, I suppose, then is within the two top lines, which are including private expenditure as well. So expenditure out of pocket by individuals and expenditure by like private health insurance. And you can see a wider gap there with the higher expenditure in Ireland. This is it's the expenditure across the 4 jurisdictions of the UK, coming from the HM Treasury in 2018, 2019. Per capita expenditure. In this year, the per capita expenditure is highest in Northern Ireland. In some other years, it can be higher in So Wales or Scotland as well. But I suppose what you're seeing here is that any sort of analysis at the UK level, it's going to be dominated by England, and often the English data isn't representative of Northern Ireland. And it's one of the things we really struggled with as well in the project and trying to get the data, is that reading through pieces, a lot of the work comes from England and from the UK, and sometimes Northern Ireland is just excluded from the analysis, or it's, you know, just kind of bundled in with the other countries. So getting that Northern Ireland specific data is challenging. This is just the uptake of screening and vaccination services around the year 2019. And I suppose the numbers that are there are relatively comparable. They're relatively high. A word of caveat, I suppose, and it's a kind of a broader issue when you're trying to do these cross-country or cross-Ireland comparisons, is that, so we mentioned at the outset that in Northern Ireland there was a list of patients, so that can be used to identify the relevant groups who are called for breast screening or cervical screening. You don't have that list in Ireland, so what happens is that various different sources are used to try to identify the relevant population, and you can imagine there's potential limitations with that, and that some people who potentially are eligible for these screening services aren't invited because we don't have a good list of the relevant individuals. In terms of the other one, just I think of interest, is the flu vaccination. So in Ireland, and this data, I suppose it predates COVID, and there has been changes in the last couple of years around the flu vaccination, but everybody over 65, it's recommended that they get the vaccination. But for those over 65 who don't have a medical card or don't have a GP visit card, they have to pay for the administration of the vaccination. So that 66% there is only for those that are actually entitled to the administration of it for free. And previous work that we've done would suggest that actually once you have to pay, you're less likely to take it up as well. So just again, reflecting the user charges in the Irish system. This is self-reported unmet healthcare needs. Again, some data issues here. So this is data, it's coming from the European Health Interview Survey, which was a survey, I think, initiated about 2010, I think, across a number of European countries. And what they were seeking to do is get harmonised data on health service utilisation, health status across European countries. Ireland wasn't there initially, but has come in subsequently. The data for Northern Ireland on the third wave, which is 2019, has been lodged with the University of Essex in England, open to researchers, but we applied for it, when we were doing the analysis, but it wasn't available to researchers at the time. So we had to use data from the earlier period, from 2014. So I suppose just a caveat in terms of the different time periods. What we're seeing, and maybe this just isn't a huge surprise, is that people talking about having unmet healthcare needs, the most commonly reported reason for having an unmet healthcare need was having to wait for healthcare services. And that was across Ireland and Northern Ireland, with a higher proportion reporting this in Northern Ireland. The bottom three then relate to affordability issues, so people foregoing health treatment because of the associated costs. And perhaps unsurprisingly, the figures there were greater in Ireland. So more people saying that they didn't have healthcare because they couldn't afford it, reflecting, I suppose, the user charges in that system. This is avoidable hospitalizations per 1,000 population. And the avoidable hospitalizations, they're generally hospitalizations that are potentially avoidable, I suppose, if people could access or did access timely and effective care in the primary or the community setting. What we're finding there for the urinary tract infection and COPD, the chronic obstructive pulmonary disease, there's actually relatively little difference. With influenza and pneumonia, we're finding a higher hospitalisation rate in Northern Ireland relative to Northern Ireland. And I suppose we were surprised by that because it would seem that the uptake of the flu vaccination is probably greater in Northern Ireland. Now, again, just I suppose caveats with these sort of cross-country and cross-border, cross-system analysis is that to do with coding? Are things coded slightly different in Northern Ireland relative to Ireland? Or is it a real difference? And I suppose being able to, if we had good data and been able to answer those sort of questions, it's really really informative, especially coming from the reform proposals, which are suggesting that we need to move care out of the hospitals into the community. This is the waiting list. So as I said, we had to provide this for the hospital setting just because we don't have data from the primary care. It's the bottom two lines first are the proportion of waiters who've been on the waiting list for at least 52 weeks. You go back to 2017, and the proportion waiting, I suppose, was quite long in both jurisdictions. It's 12% and 20. And I suppose that's long because often the targets in relation to waitings are about being treated within 12 weeks or 3 to 4 months. So you're seeing quite a high proportion of people who have very long waits. We're seeing the impact of the COVID pandemic then and the associated restrictions on activity and a very steep increase, particularly in Northern Ireland, so that by 2021, I think that's kind of mid-2021, more than half of the population that are on this waiting list have been waiting for greater than 52 weeks. The increase in Ireland is there as well, but it's not as steep. I suppose by way of summary then, and to lead into the panel discussion, there is an opportunity to learn from All Ireland analysis, I think, and for cross-country analysis in general, but it's dependent on having comparable data. And what we found is the level of comparable data was quite limited. There are cross-country data sets out there. The OECD has a number of them, but they generally provide data at the UK level. And what we generally find is that not necessarily representative of the Northern Ireland situation. There is some data sets coming from Europe, which would include Northern Ireland and Northern Ireland specific data. But we don't know what's going to happen to those, I suppose, as well in terms of Brexit and whether that will have a negative impact on the UK and Northern Ireland's participation in these data sets. There's been some positive steps, I suppose, in recent years with survey data, which is coming through, which is comparable. So a good example is the Irish longitudinal study of ageing and then the Northern Ireland cohort study on ageing as well. And a lot of overlap between those studies and a lot of opportunities there, I suppose, to look at cross-border issues from that. And has already been done with some studies. But we lack administrative data and things like waiting lists, things like expenditure. You're not going to get that information from surveys, so we need to get goes from administrative sources. And I suppose it begs the question whether there is an appetite to provide comparable data. We know that even within the particular countries, there's data limitations. So is there an appetite? It's going to take time. It'll take resources to provide comparable data. And certainly it opens up opportunities for greater research and greater coordination and greater cooperation across the jurisdictions. But we would need better data to get there. Okay, thank you. So I think we'll pass over to you, Dermot.
Oh, thank you, Sheelah.
Actually, if I could just do a brief introduction, though, for Dermot, we're very grateful to have you. So we better make sure we do the proper introductions. So as I said, this is Professor Dermot O'Neill, and Dermot's clinical professor in the School of Medicine, Dentistry and Biomedical Sciences at Queen's University, Belfast. So again, Dermot, for a variety of reasons, we're delighted to have you with us. So we'll look forward to your comments.
Thank you. Thank you to Alan and the ESRC for inviting me here, and to Sheelah and her authors for this wonderful report. And I must say I'm delighted by the timeliness of it. And again, it's nice to be reminded of what can be learned by comparing North and South. One thing I'll say about myself, just to add to the introduction, is that I'm also director of something called the Administrative Data Research Centre. So what I do, all my research is based on administrative data, making better use of the data that we currently leave all around every time we interact with various services, including health services. And what I've been asked to pick up on in the back of the report is to talk about data and research, things that I know about. I'm going to leave the complicated things like policy and cross-border interactions to the experts who know much more about this. And the other thing I want to say is I'm going to focus more on Northern Ireland, because I just know that a little better. But first, maybe I'll kick off with a short story, and it's a COVID-related story. And it goes back about a year ago when, like many other people, I was drawn in to try and help them do some research to help understand COVID. And I was working with others in Northern Ireland and across the UK, trying to understand the safety coverage and effectiveness of the various vaccines which were being rolled out at the time. And this was being led by Professor Aziz Shaz from Edinburgh, or this particular piece of work. And one of the members of our team, Declan Bradley, who was also the assistant or the deputy chief scientific advisor at the time, became aware of the potential side effects of some of the COVID vaccines, the thrombotic complications, ITP, and so on, arising from some of the vaccinations. And he wrote formally to Aziz and asked him if they could have a look to see whether in fact this was true or not, could they confirm or refute this. And Aziz says, it's not really on our work package, but we'll have a look at it. It may take us about a week and a half to come back with an answer. In fact, it took Aziz just over 2 weeks to come back with an answer, confirming what had been suggested in the Netherlands and other parts of the world, that there was a connection between, it was very low risk, but there was a connection. And this is awesome because what Aziz and his team had done was link all of the vaccine data, all of the inpatient hospital data, all of the primary care data and mortality data for 5.5 million people in Scotland. And they've done it not just for the period of the COVID, of the recent years covering the COVID epidemic, but also the 5 years previously to pick up the trends and changes over time. And they got their answer in 2 weeks. And that, I think, just demonstrates very clearly the power of what you can do if you have good, accessible data to hand. The other point, the reason I say that is that we couldn't do that in Northern Ireland. We haven't got we have the data, but we haven't got it accessible, and we haven't got the machinery in place to allow us to analyse those data. And the dearth of data is something that Sheelah mentioned there, and it's riddled all the way through that report, the paucity of data that is kicking around the place as well. And data relating to expenditure, inputs, and outcomes. And I noticed that many of the references supporting some of the changes over time go back decades, which seems kind of strange. I noticed there was other things perhaps that were missing in the report, things like social services. Of course, in Northern Ireland, we have a combined health and social services, but the data relating to social services is even more woeful than it is relating to health in Northern Ireland. And other things maybe about how the health systems are responding to health inequalities. And again, the paucity of data is probably a limiting factor there as well. The point I'm making here is that the cross-country comparisons are difficult, primarily, I think, because the data within countries is not there and not easily obtained. And that's kind of strange. I mean, when you consider the size and the amount of money that goes into running health services, not having sufficient data is a little strange. I think if you talk to some of the leaders in other large organizations, they would say that information is the lifeblood of an organization. How do you run an organization without data? How do you make new policy or evaluate policy without having the sufficient data in place? The other thing we need to know is what works. Sheelah and the authors of the report make lots of reference to the differences between the two systems and the changes that are happening within both jurisdictions, both currently and in the recent past. So that begs the question, how do we know what works? And I remember if I cast my mind back a few years, the previous major large upheaval and transformation of the health service was something called Transforming Your Care, TYC. And this was huge. It was going to be transformational. And there was lots of visions documents and consultations and strategic implementation plans at regional and smaller area levels and so on as well. And I remember asking at one of the public consultations, how much money have been set aside to evaluate the changes? And the answer was none. Nothing. And how can you possibly know what is working if we don't evaluate it carefully? I'm also thinking of a comment by Professor Nick Black from the London School, who's Professor of Health Services there, and he said there are 2 things you should not see getting made, the first of which is sausages, and the second was health policy. And I suspect the problem is the difficulties of the ingredients, in this case, information going in to inform those policies. So that's a bit negative. So what do I think needs to happen to make things better? And the first is, I think, as do the authors of the report suggest, we need better data. But I'm saying that not as a researcher. I think we need better data about the health and social services systems that we have, simply in order to make those systems work better, to allow us to understand what works and what doesn't work, and for operational and policy reasons. I also think we need this within jurisdictions. One island comparisons will follow very quickly onwards, especially if both jurisdictions are collecting data in international, in ways that are of international standards. If the data is there for operational and policy purposes, again, research will quickly follow on the back of that. Second thing is that we need to have a centralized body of expertise that can analyze these large and complex data. Understanding how the health systems work is tricky. Understanding of the data flows and its caveats and limitations is also tricky. I mean, I applaud the authors of the report in their ability to bring out nuggets of information which actually help and illustrate things, but that's been a real labor of love. The question is, why are these data not already sitting somewhere already anywhere that we can simply just tap into and then do the comparison? Why is there not ready information within Northern Ireland on avoidable hospitalizations? I don't know. So I think we need a centralized body with the expertise of doing that. I think there's lots of people doing lots of bits of research related to health services research and health policy, but I think there needs to be a centralized entity on both sides of the border. And finally, I think we need to recognize the need to evaluate our services. And we need to do that not just for ourselves within each jurisdiction, but so that other people in other jurisdictions and other parts of the world can learn from our lessons, our failures and our successes. And if those are action points, then I think they are aimed at the departments of health in each of the various jurisdictions. I think I'll leave it there, Sheelah. Thank you.
Great, thanks so much, Dermot. Actually, you've highlighted an awful lot of things, and this is following on from the report in terms of the sort of the data issues and the data gaps. And I mean, I guess one of the points that I was sort of struck reading the report earlier was the extent to which the difficulty in comparing data was less about sort of data being collected differently, but just data not being collected, or at least not being sort of brought together and made available to people. Can I ask you just very quickly, you made reference to that you chair a committee or whatever, a group on administrative data. Is there a comparable body south of the border, and do you ever talk to them?
No, I mean, I think there are a couple of ones where we look at health data, and there are a couple of organizations, both in Northern and across the UK, that's Health Data Research UK. And I think there are attempts to link all of the health data here. I think the DASL model, which was HRB, I think was trying to get off the ground a couple of years ago, would be an equivalent organization.
Okay. Yeah, no, I mean, as you can imagine, within the Institute, this is sort of one of the things we've been working on for quite a long time. Now, again, in all fairness to the Department of Health, and I've often found that when you approach administrative groups and you sort of demonstrate both the need and the desirability and the possible benefits of data, there's often sort of positive engagement. But anyway, there's a big issue there that we can return to. So listen, I better keep things moving along. So I'm sure we'll have a little bit more discussion, Dermot, in a few moments. But now I'd like to go to Anne Nolan, who is Assistant Professor Public Health and Primary Care in Trinity College, Dublin. So, Anne, it's a great pleasure to kind of welcome you to the ESRI, and we'll look forward to your comments.
Well, thank you so much, Alan. You're an advertisement for how to get over COVID. You're looking great, so hopefully I'll be feeling a bit better soon as well.
Actually, I looked infinitely better than this a few weeks ago, though, Anne, so don't be fooled.
Okay, Thanks so much, Alan, and to the ESRI and Sheelah and your team for a really excellent report. And another piece in the jigsaw, I think, in how we can, in the different areas of healthcare where we have shared working and understanding. Your report is incredibly important, and it made for a really interesting read, Sheelah, and all the team. So thanks so much for that. You asked me to comment really in the context of a study that we undertook in public health and primary care in Trinity College, Dublin, in the wake of the first wave of the pandemic. And what we were interested in was looking at levels of alignment of public health policies for COVID-19 in Northern Ireland and the Republic across the first wave of the pandemic. And we used the Oxford COVID-19 Governance Response Tracker, which of course is an international instrument for measuring and assessing policy for COVID-19 internationally. So, and interestingly, the Oxford team had also used it as a measure for all of the 4 jurisdictions in the UK, and also encountered, even within the UK, huge challenges in terms of comparability of data and the operationalization of multilateral guidance for COVID across the board. I think it's important, I think, to just put out there at the very outset that our primary finding was essentially that, notwithstanding perceptions, and there were a lot of perceptions to the contrary at the time, that there actually was very strong public health policy alignment for COVID-19 on the island of Ireland throughout the first wave of the pandemic. We looked at a number of over 12 health and containment measures, and what we found was that ultimately, the Good Friday Agreement, which includes institutional structures for collaboration north-south and with health as one of the key priority areas, had delivered a strong framework for political engagement and subsequently health system engagement as a result of that. There were differences in the interpretation of multilateral guidance in each of the jurisdictions based on system capacity, and a number of other reasons as well. And there are some specific areas where we really struggled to compare data. I'll come back to that. It was specifically in relation to testing, but also, I mean, one key area was in antigen tests were widely used in Northern Ireland, and really only the self-testing mechanisms really only came into being in September 2021 in Ireland, and then testing capacity, and the promise, of course, to scale up symptomatic testing with eligibility threshold had to be lowered in order to take account of system capacity. Again, the way this was communicated had very different impacts, with the perception that Northern Ireland was actually following a system in which community testing wasn't taking place, but actually we weren't either. We were just wording it very differently, which left the media to think that we were taking a radically different step. We actually weren't when we dug down into that. What we found was, and I think this has turned up a lot, it turns up, it's very salient in your study, Sheelah, about all the precedents that exist in different thematic areas for health, in cancer care, in my own area over a number of years, which is HIV, the Irish AIDS Initiative. Under the 30-year rule, we have a huge number of parliamentary documents and governmental documents that showed there was a huge amount of discussion and agreement around the response to HIV/AIDS in the 1980s between the ministers in the north and the south at the time, or the secretary in the north. And we also, of course, have a number of initiatives in cancer care. And this latest study on primary care is a part of that long tradition that's actually spanning over decades, that is built on relationships and goodwill between individuals and people. And from a political perspective, I suppose what we found, and is that the Good Friday Agreement, resulting in the MOU on the 7th of April 2020, that is then backed up by regular, at least weekly, conversations between NPHET and the Public Health Agency on COVID-19, and weekly dialogue between the CMOs in each jurisdiction, resulted in a significant level of alignment in relation to policy. There were, if you drill down, of course, there were differences in implementation based on the different political economies and system structures in each jurisdiction, and some differences in interpretation of multilateral guidance. But broadly, we just looked at the top line of the policies, there was very close alignment. What comes across, I think, not only in our study, but also in your study, Sheelah, and then all of those examples and studies that we know that go back to the 1980s, is that personal relationships play a really significant role in enabling alignment and cooperation and coherence. And we have multiple really good examples of that on the island of Ireland, coupled with the Good Friday Agreement, which provides the top-down or the political layer commitment. I consider myself very much an accidental academic, whereas I come from a public service and a civil service background. So I'm an unusual beast in the sense that I've made the leap into academia. So whereas there seems to be a fundamental distrust of what our political system or leaders were saying at the time, which led to the perception that there was very little cooperation or alignment, that actually, I suppose when you look at the policy documents at Hansard, at parliamentary debates, at the minutes made available by the Department of Public Health and the Public Health Agency, I as a former civil servant, I know that you can trust to that there's no way that information is being put in there if that dialogue is not taking place. Everybody and all civil servants will take the Good Friday Agreement incredibly seriously and important, foreground it in their efforts. Since our study was undertaken, which also included some focus groups across the border, we found a lot of bottom-up support for greater alignment and cooperation in primary care. These are not generalizable findings. They're small focus groups on both sides of the border. But again, I was working last week with Jennifer Todd and Joanne McAvoy from UCD and the University of Aberdeen with IRC-funded study with women's groups on both sides of the border. And we were talking a lot about, the ways in which primary care can dialogue with and citizens can access different services on both sides of the border. I think what really comes across to me in both the top down and the bottom up efforts is that you have civil society very strongly supporting greater collaboration and cooperation, and the political institutions also supporting greater collaboration and institution for health, whether that be tertiary healthcare, primary healthcare, public health across the island of Ireland. Where we're missing is what leads me on, I think, to, and I don't want to be repeating what everybody else said, but, the critical first steps, if you like, have been achieved in acquiring political alignment and political buy-in and what seems to be broad citizen engagement in the idea of an all-island response to health. But Dermot has said it, Sheelah, you've talked about it a lot. The minister has talked about it. Alan has raised it as well. Of course, the big issue is in relation to the lack of comparable data for, and that hasn't improved over time, even though many of these studies that have highlighted these differences, and indeed we identified them in the era of HIV and those first initial outbreaks in terms of sharing data about testing and prevention efforts. These were huge issues in the 1980s, and they continue to be so. So, you know, one of the things that in the dialogue last week that came forward is a lot of the citizens groups were calling for a citizens assembly to move that dialogue forward. That strikes me, I think, as moot in the sense that I believe, you know, the only thing that is going to achieve is political buy-in. We already have that. So realistically, the next step is to do what we're perhaps all putting on the long finger, which is to find entry points for data comparability. It would be a very large undertaking, but even starting with, I think your study, Sheelah, provides a number of entry points for that. And as Dermot said, we actually can't move forward. And we know this now for the last 4 decades. So I think we just need to act on it rather than constantly producing more reports in different areas of healthcare, and actually take the difficult next step, which is finding those entry points for data comparability and alignment that would then allow us to move to the next step. So, you know, I think the way forward is probably clear. The challenges, though, inherent in that are problematic, as you've already identified, Sheelah and team.
Great, thanks so much, Anne. That was a fascinating from a whole range of perspectives, actually. But can I limit myself to one quick question?
Sure.
I think you made reference to qualitative engagement on this sort of question of service integration or whatever like that, or collaboration. And I suppose the thing I'm interested is the following. Very often, certainly in the South, you know, there's this sort of view is often expressed that the people north of the border are very attached to the NHS, have this feeling of the sort of the, you know, the value. Now, whether it's correct or not, but you know what I mean, that they this wonderful health service. And that there would be concerns about sort of any sort of integration or collaboration could be then lead to a dilution, you know what I mean?
Yes,
and I'm just wondering, did that theme come now? I know we're sort of veering into, I don't even mean this in a political sort of way, but I think it's very interesting when you talk there about civil society having particular perspectives on this, and you know, very often maybe, you know, further along than some of the political leaders. But anyway, can I just get your reaction to that? Did that sort of question of dilution come up in your discussions? And what
it's really interesting, actually, Alan, because what we found is that it didn't really emerge as an issue either with the women's groups both sides of the border or in the small number of focus groups that the Contain study that Trinity undertook. What people found was and felt and articulated, and we see this, of course, again and again and again in so many ways, people felt that the political system was out of step with what people themselves want. Where health is a priority now, you get this very unrealistic claim about taking the politics out of healthcare. And as we know, you know, health is intrinsically a political issue, and how we deliver it is political. But people see it as something that is common to each political system in each jurisdiction, is a priority for citizens both sides of the border. And where people really struggled, particularly in the context of COVID-19, is not really understanding why it had to be something that Stormont or the Irish Prime Minister would be involved in. Why can we just not leave it to the experts? Now, there's a lot of naivety, of course, inherent in that perception. But in answer to your question, there didn't really seem to be any real barriers presented in terms of having a more all-island approach. These were border communities who felt that they were kind of torn between two systems, working on one side, maybe living on another side, and caught somewhere in the middle. And it just didn't make logical sense to people's everyday lives. And again, just that reality of politics being out of step with what people perceive as important to them.
Sure, great. Thanks so much for that. Before I turn to Tom, can I just say, hopefully we'll have a couple, well, maybe more than a couple of minutes at the end of the panel. So if people want to submit questions through the Q&A function, that would be great. I'm happy to report there's a very lively discussion happening through the chat function. So good to see that people are making good use of that. But specifically then, if you want to put questions to Sheelah or any other member of the panel, that could happen through the Q&A function. That would be very, very good. Now, with that, it's my great pleasure to turn to our third and final panelist. This is Dr. Tom Black, who's Council Chair of the Biomedical Association Northern Ireland. And again, Tom, you're very, very welcome to the ESRI, and we're very delighted and honoured that you've come along to share your thoughts with us today. So over to you, Tom.
Thanks, Alan. Thanks, Sheelah, and thanks to ESRI for the invite, and to the report authors. It's a fascinating report, and I certainly take a lot of this home with me. I'm the union leader for the Medical Association of Northern Ireland. I look after the doctors and the medical students, so we have that view of the health service. But the British Medical Association has always been a professional association that looks at the service for patients. I'm a GP in the Bogside in Derry. I trained in Dublin, in University College Dublin in 1970s and 80s through the Mater Hospital. I then worked in hospitals in Northern Ireland, hospitals across the border in Donegal, and spent my last 30 years as a GP. So that's the perspective. I've also sat on more review panels for reforming the health service than is good for anybody. Going back to the Hayes Review, which was Senator Morris Hayes in 2000. And I was also on TYC in the reference panel. And thankfully, I managed to duck the Bangor report, which was excellent. The challenges we have are similar. They're challenges of what's the needs of the patients, what's our wants, what's our demands, and discriminating between those three. The challenges of the increasing costs of the health service. The NHS was set up in 1948 and they spent 130 million on it. It's now 200 billion. Phenomenal numbers for the UK. Workforce shortages throughout these islands and difficulties in terms of access to care, and in particular with hospital waiting lists. And Sheelah portrayed that very well in her presentation. In Northern Ireland, and indeed in the United Kingdom, we love the NHS. It is like a religion. Like a religion. We adhere to the Bevanite principles of Anyer and Bevan's universal free at the point of need, keyword need, and funded by taxation. That's how we like our health service. But it creates problems because it reduces the spend. And again, we saw this in terms of public spend and private spend. We also struggle with what is the need of the population, what is the health service there to provide, and we think of it in some terms as, in some ways, as part of the glue that holds our society together. But what do the public want? What do they need? What are they demanding? What's the most important? And if you go out and go to all the town halls, they'll say the same things every time. What are the most important things? General practice, emergency department, pediatrics, maternity, geriatrics, and cancer services. Those six, that's what they say. I know we provide lots of other services above and beyond those six, but those are the core services that patients, the public, our community value. We know from this report and from every other report that we've seen that we have to focus on primary care, provide as much care as close to patients as possible in the community, focus on health promotion, prevention. We heard that from Minister Donnelly. We've heard that from every politician down the years, and we know that from all our reports. But the health service never stays the same. New drugs, new procedures, different ways of dealing with it. When I started as a doctor all those years ago, it was all about acute care. It was about heart attacks, strokes, meningitis, epiglottitis. Some of those diseases don't exist now. Very rare meningitis, epiglottitis, haven't seen it in 20 years. Why? Because of primary, secondary prevention. Then my job became one of chronic disease management, diabetes, ischemic heart disease, hypertension, heart failure. And that was the 90s and the noughties. And now we're into the third phase of my career where the jobs again completely changed, and we're dealing with the management of complex comorbidities, polypharmacy, integrated care. So the health service progresses and moves on, is never the same. And obviously we're into the new phase of gene therapy and biologic treatments and all that. So what are the priorities? What do we need to focus on? Obviously, I'm going to say this as the union leader, the doctor who represents doctors. We need to discriminate between needs, wants, and demands. We'd like to deal with patients' needs rather than their demands and their wants. I know that's a little patronising from the sound of it, but actually that's the most important thing for the patients as well, because if we're dealing with needs, then everybody gets a better access to the service. The report talks about GPs as gatekeepers, and in the UK now we actually have gone past that, and we try not to talk about gatekeepers. We talk about GPs and general practice and primary care as care navigators and providers. And in Northern Ireland now, we're actually leading the way in this with GP federations. And GP federations are not-for-profit companies which are set up to provide all the multidisciplinary team staff that works for the patients in primary care. And that covers all practices in Northern Ireland now. And not all of them have the full multidisciplinary team, but for instance, they all have nurses, nurse practitioners, and pharmacists. So every practice in Northern Ireland has a pharmacist dealing with the endless numbers of prescriptions. 42 million prescriptions per year in Northern Ireland, 1 billion prescriptions per year in the United Kingdom. A phenomenal number, 1 billion per year. And those GP federations employ these multidisciplinary team members into the practice. So in my Bogside practice in Derry with high deprivation, I have a pharmacist, 2 social workers, a nurse practitioner, a mental health worker, musculoskeletal physio type of person, along with the pharmacists, the GPs, the nurses, and all the other staff. That's a phenomenal service provided through the NHS, free at the point of need. It's very clear that if I said one of the priorities was to increase funding and increase the workforce, we'd all recognise that, but that's difficult in the world that we live in. Some important things is that we need to devolve funding down as close as possible to primary care, to the communities, to provide services as close to them. We need to, if we can, bring the funding down to that level and develop reciprocity where the patients and the communities have direct influence on the provision of services. As a worker in the NHS, I would say we need universal registration with the GP and an electronic care record. So if you're in a hospital in Northern Ireland, those doctors and patients can view the record from the GP practice, which holds everything in the NHS. I would also say it should be universal, free at the point of need. Our biggest problem at the moment is waiting lists. With huge waiting lists in Northern Ireland, huge waiting lists in the United Kingdom, the patient journey is very fractured at the moment. Really difficult getting patients through the system in terms of access, diagnosis, staging and treatment in terms of surgical or cancer therapy or chemotherapy for patients. Really difficult. I heard Minister Donnelly talking about elective hospitals, and we're looking at the same thing in Northern Ireland. How do you transform secondary care to provide the most efficient and effective services for patients? I think you don't fix the health service, you make it better incrementally. But if I had one message today, it's to engage the patients, engage the communities, bring the decision-making as close as possible to the patient if we can. Remove this notion that patients are there as passive recipients of state largesse. They aren't. They pay for this. We are their servants, and we should give them a service that is as efficient and as effective as possible and catering to their needs. Thank you.
Thanks very much, Tom. Again, more fascinating insights. And I'm going to slightly abuse my position as chair, but because you're here, Tom, there's a kind of question I want to ask you, given your perspective, partly because you're a GP based in Derry and probably can take a look over the border from time to time to see what's happening. One of the things I'm really interested in about Northern Ireland is this notion of healthcare and social care, I'm going to say sort of supposedly being integrated. Okay, and as you'll know then, in the Republic, a lot of initiatives in recent years around home care packages and the sort of desire to build up social care. Now, again, sort of reflecting on the way you sort of developed, the various stages of your career, I presume population aging is sort of manifesting itself in GP practices as well. So sort of this issue of, how we sort of manage an older population and the integration of social care with primary care and further care. And I'm just wondering, in the spirit of today's discussion, are there lessons for how things are done in Northern Ireland for the South, or are there lessons from the south for Northern Ireland in terms of that interaction between social and primary care and beyond?
I think that we can learn a lot from each other, and we heard Anne about during the COVID and how much we learned from each other. I think that there are a few fundamental principles, laws of physics, you could call them, in life. One is that there's a big magnet in every major hospital that sucks all the funding into it. And if you combine the funding between primary and secondary care always wins. Why? Because the only thing that counts are those things that you can count. And obviously waiting lists attract all the funding. So you have to be very careful to be able to increase funding into general practice, into primary and community care. The integrated system of health and social care in Northern Ireland should make everything better, and yet we struggle. We know that the biggest problem in hospitals now, and great sympathy with my hospital colleagues, because EDs are under huge pressure, COVID wards, general wards are under huge pressure, and what I talked about, the complex comorbidities in polypharmacy mean that our patients are very often older with greater comorbidities, and it's very difficult to get them through the system and out the other side into care facilities or care packages. And it shouldn't be, because we have integrated health and social care, and yet we have the same, if not more problems with that than everywhere else. So there are just some laws of physics that are hard to get past.
Okay, again, it's a conversation we'll carry on. Now, I am going to take some of the questions that have come through the Q&A function, and hopefully this will sort of further illuminate the discussion. So, and the first one is Sheelah, rather, the first one is for you, and this is quite direct from Anthony Staines. The question is, what's the source of the list of avoidable hospitalizations? And Anthony goes on to say, there are several in the literature, but I don't think I've seen your list before. So have you got insights on that one?
Yeah, there's details, I suppose, greater detail in the report, and there's a couple of papers that have been done, Northern Ireland, Ireland, and the UK more generally. So the methods there, and I suppose the chosen the conditions that we include here are based on a wider, I suppose, list of conditions. We use those ones because they're quite common, but there's more detail in the report in terms of the actual, I suppose, the source of those.
Okay, and just a supplementary on that, I presume with universal free access to primary care in Northern Ireland and not in the South, the expectation would have been that such avoidable hospitalisation should have been lower in Northern Ireland. I mean, I'm just sort of thinking through the theory, presumably that, but if memory serves you right from your slides, with influenza and something else, they were actually higher in Northern Ireland. Now, I think it reversed in another one, but again, you were probably a little bit surprised with the... Yeah,
well, in particular in relation to the influenza and pneumonia, because we know that the influenza vaccination is free for all the recommended groups in Northern Ireland. That's not the case in Ireland, so we expected to see the reverse. So yeah, that was an unexpected finding, I suppose. But again, we can't say whether that's a real finding or whether it's something to do with just differences in how things are measured north and south. So again, we just need to try and dig into that a little deeper.
Okay, now the next question is from Sarah Boyce, and I think all the panel might have a view on this one. I'll just read out the question. So it's about mental health, and good that we're getting an opportunity to talk about this. So mental health is a massive issue north and south of the island. Recent research by the Mental Health Foundation found that the economic cost of mental health in the north alone is around 3.4 billion annually. I'm wondering, is that the cost of the difficulties associated? But anyway, we can come back to that. Wondering if there's any comparative analysis of mental health services north and south, or if any work going on to think about the different and better models of mental health care. So Sheelah, maybe you would sort of deal with it first, but I think I'm sure the other panel members will have a take on that one.
Yeah, I'm not aware of anything. So I mean, we didn't specifically look at mental health for our report, but certainly nothing jumps out at me. But I know, Dermot, you were doing something around suicide in that north-south.
So there was another call recently looking at north-south collaboration research, and from the HEA, was it? I forget, but that was and there was an embryonic consortia from both Cork and Belfast and Coleraine, bringing together most of the mental health researchers, both north and south of the border, under the banner of Sparkle, I think it was called. And I think there are, even though that wasn't funded, I think there are moves now to keep that going. And once the connections have been made, then to keep to start looking for additional funding strands to see how we can best coordinate both what we know about the data for both suicides, for self-harm, and again, the self-harm register, which started in Cork and then eventually came into Derry initially and then into the rest of Northern Ireland, is now in the good collaboration north and south for that. And then what we can do about improving our mental health services on top of that.
Okay. And is mental health that something came up in the context of the research you're doing? On your head? No, it's like, okay. And Tom, I'm sure you have a view on this as well.
There's been a huge increase in mental health problems, particularly after COVID. I see that as the biggest challenge that we have. Long COVID would be small compared to the mental health components. I think certainly the thing that has improved services most for the community in Northern Ireland is the mental health workers as part of the multidisciplinary team. So we actually have, not yet everywhere, but probably in about half the practices, a mental health worker. Our big problem was you can diagnose it, you can try and treat it with medication, but once you tried to refer through to secondary care services, there was huge delays and huge backlogs, and that's just the sheer volume of need out there for mental health issues. By having a mental health worker in the practice who's accessible that same day has really improved the working of GPs, but most importantly, the care for patients.
Okay, thanks for that. Actually, I just see again the Jaffa Helen Johnson from the National Economic and Social Council has let us know that there was a Shared Island report on mental health published earlier this year, so that'll be one that we must explore. We're coming sort of towards the end of our discussion, and Sheelah, I'm sort of eager to go back to you, perhaps for sort of some concluding thoughts. And I suppose when I was sort of delivering my introductory remarks, I was sort of saying that one of the objectives here was to sort of maybe, learn best practice or whatever. And I had assumed that health would be one of those areas. But it really does sort of seem that when you stepped into it, that the data gaps and the data considerations were such that really we're a bit of a distance if we think we can start learning huge amounts in terms of best practice. And that really it's that maybe the sort of the greater effort should be on the data side. So I suppose firstly, is that a reasonable assessment? And then I suppose the thing would be, what would be useful next steps, do you think, in terms of filling that data gap, partly in a sort of a shared island context?
Yeah, no, I think that's a fair assessment. I suppose the one thing that does come out, which, we probably knew this anyway, but it's a lesson, is that, but there has been a lot of talk around the Sláinte Care proposals about removing user charges. And obviously that's important in facilitating access to healthcare services, but it's only part of the issue that if you reduce user charges, if you don't have the additional workforce there to meet the additional demand, you'll see what's happening in Northern Ireland and what's happening in Ireland with the long waits. So it's, you need to think more broadly. And I think that comes out from the report. I think, we did kind of a broad brush of various indicators. And I think we probably identified more questions than we actually answered. And I think there's real opportunities. And I think something around the avoidable hospitalizations, if we are, interested in identifying and moving care out of the community, because things like the quality and outcomes framework in Northern Ireland, part of the reason for introducing that was to reduce avoidable hospitalizations. And I suppose digging down and trying to identify, well, are these real differences between Ireland and Northern Ireland? And if they are, trying to dig down further and to work out what is going on. But again, you're right, where, databases we're very far away from that. And even within the countries, and trying to understand what's going on with the waiting and how people are, going across the different sectors and the different parts of the waiting list. We don't know that within our own countries. So trying to do something sort of comparable work, is nearly an extra step along as well.
Very good. Well, thanks for that. I mean, as ever, a good research report should generate as many questions as answers. So that's all very, very positive. Now, we've hit 20 past 12 and said at the outset that we would try and conclude around now. So I just want to finally, once again, thank Tom, Dermot and Anne for coming along and giving the benefits of their insights. I very much enjoyed it. Again, I want to thank the colleagues in the Shared Island unit for the sort of ongoing engagement with this and the broader research program. And I think everybody will allow me, if I can finally thank Sheelah, Aoife Brick, of course, Kieran O'Neill and Michael O'Callaghan, the authors of the report. It has been a really, really good piece of work, really stimulating, and I've little doubt it will sort of give rise to further discussion and engagement. And of course, finally to you, Sheelah, then for such an excellent presentation earlier on. Really, really enjoyed it. So thanks to everybody for logging on today. As I said, we'll be continuing with the webinar series, Shared Island related matters in the coming months, and of course a variety of other things too. So great to see everybody, and look forward to talking to you all soon. So good afternoon.